Hi guys. Today's lecture is going to be on the evaluation and management of atrial fibrillation and valvular heart disease. I'm going to talk briefly to you about atrial fibrillation, definition of it, and for some of you who are not familiar with or comfortable with EKG monitoring, I'm not going to talk a lot about 12-lead EKGs today, but you should have a basic understanding of what a PR interval is, measurement of QRS, measurement of QT, and QTC. So please reach out to me if you'd like me to do an individual review with you. I'll be happy to do that. So atrial fibrillation is an atrial rate in excess of 300 beats per minute. With atrial fibrillation, the atria is actually beating at can beat up to 350 beats per minute to 600, so 350 to 600. It has a variable ventricular conduction from 120 to 200 beats per minute. It has no discernible P waves. It has a rapid re-entry impulses. Rapid atrial fibrillation causes incomplete contractions and ineffective emptying of the atria. So the atria are not squeezing uniformly and in harmony that they normally do. With atrial fib, they're fibrillating and they're not squeezing that blood out from the atria to the ventricles, which makes them at risk for clotting. However, it also leads to a decrease in cardiac output, just like I said, a stasis of blood. And this rhythm is responsible for 15 to 24% of strokes. So in a normal sinus rhythm, with normal hemodynamics of a patient, you have one P wave to one QRS to one T wave. The PR interval is, with the electrical conduction system, the PR interval should be no greater than 0.20 seconds. And there should always be just one P wave to one QRS. In atrial fibrillation, you cannot discern the P wave. A lot of times you'll be looking at the P wave and trying to see if there's a P wave, and there's not. So when we talk about this one P wave to one QRS to one T, one P to QRS to T, one P to QRS to T. The PR interval is the beginning of the P wave to the beginning of the Q wave, even though it's called a PR interval. A normal PR interval is no more than 0.20 seconds. It's from 0.12 seconds to 0.20 seconds. The QRS should not be greater than 0.12 seconds, and a QT interval from the beginning of the Q to all the way to the end of the T measures ventricular depolarization and repolarization. That's QT. That's normal sinus rhythm. With atrial fib, remember I said there's only one P wave to one QRS. You cannot see where the P wave is. There's no discernible P wave here. Lots of fibrillation. When we talk about a rate of over 600, if you measure this to here, that's where the atria is beating at 600 beats per minute. 600, very fast when they talk about 3 to 600. If you measure that out, it's like close to 600. So, and the AV node really helps to protect the ventricles from, the AV node stops the atria from shooting that 600, that rate very fast to the ventricles. The AV node becomes that safeguard and stops the ventricles from firing to 600. So atrial fibrillation is the most common dysrhythmia. It affects 2 to 4% of the population. It affects over 2 million Americans, 5% over the age of 65 and 8% over the age of 80. Affects more men than women. Signs and symptoms of atrial fibrillation include palpitations, angina, fatigue, dyspnea, syncope, tachycardia, irregular pulse, and hypotension. Associations often related to underlying disease process, and that includes rheumatic heart disease, mitral valve disease, aortic stenosis, hypertension, coronary heart disease, cardiomyopathy, hyperthyroidism, thyrotoxicosis, acute alcohol intoxication or withdrawal. A lot of college kids can transiently go into AFib after they've had too much to drink. And usually it's self-limiting. With some fluids, we usually can reverse them around and they come out of it. But that's a very common thing that does occur. Not normal drinking, but it does occur. Stimulant ingestion, pulmonary disease, and pericarditis. Classification of atrial fib. First detected atrial fib. Recurrent atrial fib, 2 or more episodes. Paroxysmal, ending within 7 days. Chronic, lasting more than 7 days. And persistent, greater than 1 year. And lone atrial fibrillation, the definition is no clinical findings of cardiopulmonary disease or echocardiographic reasons for the onset. Evaluation of AFib, required evaluation, history and physical, EKG, chest x-ray, blood tests for thyroid function, additional testing, stress test, Holter monitor or vent monitor, transesophageal echo, and EP studies might be required as well. So on the history, we want to describe, are there any palpitations? You want to ask them the onset of the atrial fib, the pattern, and how long. Those are very important in the history of present illness. Describe, do they have any palpitations, any shortness of breath, any fatigue, dizziness, any near syncope or syncope, leg edema or calf pain. Inquire about chest pain. This is indicative of ischemic heart disease or PE, pulmonary embolism. Any changes in weight, mood, hair loss, heat or cold intolerance, tremors associated with thyroid disorders, especially thyrotoxicosis. Are they having any precipitating factors? Stress, sleep deprivation, unusual activity, excessive caffeine or alcohol ingestion of a large meal, any recent drug use. Medical history, we want to focus on cardiovascular, respiratory, neurologic systems. Family medical history, medication history, and quality of life issues. A physical exam, general appearance, including vital signs. Eye exam, you want to assess the neck, the thyroid, JVD, and any bruise of the neck. You want to assess the skin, respiratory, cardiac, including postural or orthostatic hypertension. Echo must be done on a patient currently experiencing AFib, especially prior to cardioversion. What you're looking for is the presence or absence of left atrial thrombus. Transesophageal echo is expensive, but really the best at identifying left atrial thrombi. Helpful in predicting the success of cardioversion. A dilated left atrium or severe left ventricular failure has a slow success rate as it pertains to cardioversion. Other diagnostics are metabolic panel, CBC, EKG with or without exercise. If PE is suspected, you order a D-dimer if that's indicated. Remember, we're going to do, I didn't talk to you about perk tests, but I will talk to you in class about perk tests. Because if you can perk them then you can do a D-dimer. But if you can't perk them, then you might have to go right to the chest, CT of the chest. If congestive heart failure is suspected, you want to order a BMP. Two-dimensional transthoracic echocardiogram may be needed, and this looks at left atria and left ventricular size, looks at systolic function, and underlying structural heart disease. It also measures cardiac wall motion and contractility of the left ventricle, and we're looking at ejection fraction. and a normal ejection fraction is greater than 50%. And what the 12-lead EKG, we're looking at the rhythm. We need to verify this rhythm. Is this atrial fib? We're looking at the EKG to see if there's left ventricular hypertrophy. We're looking at P wave duration and shape or fibrillatory wave. Does the patient have a bundle branch block? The EKG can tell us. Does the patient have a prior MI? Does the patient have other atrial arrhythmias? We want to measure and follow R to R. We want to look at the QRS and QT intervals, and that's very important if they're going to be going on specific anti-arrhythmic medications. You want to make sure that their QTC is within normal limits, because some of these anti-arrhythmic are prone to increase QTC, prolonged QTC, so you have to be very careful, and a lot of times they need to come into the hospital for medication administration to try to convert them. Therapeutic goals for atrial fib is rate control, prevention of thromboembolism, restoration and maintenance of normal sinus rhythm. So rate control, clot control, cardioversion. Our goals is to prevent stroke. That's the ultimate goal. We want the rate control, we want to control ventricular rate. Rate is considered control when the ventricular response the response ranges from 60 to 80 beats per minute at rest and 90 to 115 beats per minute with moderate exercise. Clot control, anticoagulation therapy, the balance between key here, stroke prevention and avoidance of hemorrhagic complications. Restoration and maintenance of normal sinus rhythm, and cardioversion, either pharmacologic or electrical, as therapeutic goals. Ventricular rate control, we want to achieve a rate of less than 100 beats per minute with beta blockers, calcium channel blockers, digoxin. Beta blocker and calcium channel blockers are drugs of choice because they provide rapid rate control. Beta blockers are preferable in patients with MI or angina. Digoxin is less effective for ventricular rate control. It's a slower onset of action. Digoxin is also a positive inotrope and is very useful with patients with systolic heart failure. Hospitalization is usually required for acute atrial fibrillation, particularly if the ventricular rate is greater than 170 or less than 40 beats per minute, or if the patient has underlying cardiac disease. If a patient is hemodynamically compromised, immediate electrocardioversion is performed. This most of the time does not occur without another medical condition going on, like acute CHF with rapid AFib. There's usually something else going on that we need to cardiovert these patients. So oral dig often is for patients with heart failure, left ventricular dysfunction. Initial and subsequent management of symptomatic heart failure may differ from one patient to another. So that is one treatment. For symptomatic atrial fib lasting weeks, initial therapy may be anticoagulation and rate control. The long-term goal is to restore sinus rhythm. So for symptomatic AFib lasting weeks, initial therapy may be anticoagulation and rate control. And then long-term is to restore sinus rhythm. So decreasing symptoms by rate control for elderly people may eliminate the need to restore sinus rhythm. So patients oftentimes present because they're symptomatic, because their heart rate is so high. The goal for an elderly person might not be to cardioverter them into normal sinus rhythm. Prevention of thromboembolism, you may start patient on IV heparin for rapid anticoagulation. This is a bridge to Coumadin. It takes approximately 5 days to reach full anticoagulant effect. Initially, we'll start them on heparin. They can become therapeutic in less than 6 hours. And we start heparin and Coumadin at the same time, and the goal is to have the INR be greater than 2.0 before we discontinue the Coumadin. So the PT INR, the target INR, is between 2 and 3. INR weekly until stabilized in outpatient setting, and once therapeutic, INR monthly. So patients with mechanical heart valves, their target INR is different based on the type of valve that they have. They might have an INR greater than 2.5, depending, usually that's a mitral valve that requires that. Contraindications of anticoagulation therapy, absolute the presence of severe or active bleeding, the patient is non-compliant, first trimester of pregnancy, relative contraindications, uncontrolled hypertension, systolic blood pressure 180, diastolic greater than 100, severe liver disease, recent surgery involving the nervous system, spine, or eye. American Heart, American College of Cardiology Treatment Guidelines, age and risk factors. Someone who's less than 60 years old. The other one is ESC is the European Society of Cardiology. So the American College of Cardiologists, ACC, AHA is American Heart Association, and ESC is European Society of Cardiology. So age and risk factors, someone who's less than 60 without heart disease or lone AFib, treatment recommendation is aspirin 325 milligrams daily or no therapy. Someone who's less than 60 with heart disease, no risk factors, aspirin 325 milligrams daily. Someone who's greater than 60, no risk factors, aspirin 325 milligrams daily. Someone who's greater than 60, diabetes or coronary artery disease, we potentially could, the Coumadin or the new oral anticoagulants, and we're going to talk more specifically in class about those, and we're going to titrate to an INR 2 to 3. Addition of aspirin is optional. And again, a lot of these, you would consult a specialist. And a lot of primary cares oftentimes have good relationships with the cardiologist. I recommend that. But, you know, when you consult, you are spreading liability around. Meaning, you know, you are consulting, you are asking an expert if this is what they choose based on good practice. Greater than 75 years, especially female, warfarin, INR 2 to 3, CHF, left ventricular ejection fraction, less than 35, hypertension or thyrotoxicosis, Coumadin or the new oral anticoagulants, INR 2 to 3. Rheumatic heart disease, mitral stenosis, valve replacement, prior atrial thrombi or persistent atrial thrombus on TEE, Coumadin. American College of Chest Physicians, a low age less than 65, no additional risk factors, aspirin. Intermediate age 65 to 75, diabetes or coronary artery disease, warfarin or new oral anticoagulants, or aspirin 325 milligrams PO daily. High age greater than 75, history of hypertension, left ventricular dysfunction, more than one intermediate risk factor, mitral valve disease, prosthetic heart valve, history of stroke, TIA, or systemic embolism is Coumadin 2 to 3, target INR 2.5. There are oral anticoagulants. Pradaxa is useful as an alternative to Coumadin in patients with non-valvular AFib, no significant valvular heart disease, and these patients have to be without severe renal disease or advanced liver disease. Creatinine clearance, these patients need to have greater than 15 to 30, or at least a creatinine clearance greater than 30. Pradaxa is 75 milligrams BID or 150 milligrams twice a day. Individual patient characteristics on these new oral anticoagulants, such as kidney function and certain medications, are critical factors in contributing to the risk of bleeding. So you have to look at the whole picture and make sure there's nothing that would contraindicate them from getting Pradaxa. There's other new anticoagulations, the Pradaxa, Xarelto, Eliquis, and Cyazypyr, which is fairly new, that came out in the market last year. Though all four are FDA approved for non-valvular heart disease with atrial fibrillation. So with any type of warfarin therapy, i.e. new oral anticoagulants, the new ones, you want to obtain a CBC, a urinalysis, a PT, an INR, a platelet count. For Coumadin, initial therapy will be either between 2 and 5 milligrams daily as fixed dose. Half-life of warfarin is 31 to 51 hours, and the steady state is achieved in 5 to 7 days. So also they talked a little bit about, with the oral anticoagulants, their half-life is a lot shorter than Coumadin. And this has a particular interest in you guys, because if a patient misses a lot of doses, it's better, and they're non-compliant, for these patients to be placed on Coumadin, because Coumadin has a longer half-life, allowing for some stroke prevention. So if they skip a dose, they will have some stroke prevention, whereas the new oral anticoagulants have a quick half-life. So if they miss a dose, they're more at risk for stroke. Initiation of warfarin should be 5 milligrams a day in most patients, and again, that will be tweaked depending on what's going on with your patient. A starting dose of less than 5 milligrams should be considered for individuals greater than 70 years old, patients that weigh less than 45 kilos, patients that have liver disorder, and previously documented sensitivity to Coumadin. Therapeutic INR range. The target INR range is 2 to 3 for most indications for Coumadin therapy. The target INR range is 2.5 to 3.5, indicated for prosthetic heart valves, thromboembolism, when INR already is 2 to 3. Frequency of INR monitoring. In the induction phase, INR should be monitored every 1 to 3 days until INR is in target range for 2 consecutive values. One stable every 1 to 4 weeks, depending on the stability of the results. INR 2 to 3 times a week in concurrent illness, medication change, and significant diet change. Remember, green leafy vegetables can lower your INR, and you have to teach patients about that. Here's dosage adjustments. Target INR 2 to 3. Most Coumadin clinics have a very tweaked ability to protocols on how to adjust the INR, and I think Kathy Polk does all her INR, so it'll be interesting. It's adjusted via protocols. So with an INR of less than 1.5, you want to increase the total warfarin dose by 10 to 20% and get an INR in 1 week, might be in a couple days, at least greater than 3. An INR between 1.5 and 1.8, you want to increase the total warfarin dose by 5 to 15% and check an INR in 1 week. An INR between 1.8 to 1.9, same dose, INR in 2 weeks. An INR 2 to 3, no change. INR in 4 weeks. INR 3.1 to 3.3, no change. INR in 1 week. An INR 3.4 to 3.9, decrease total warfarin dose by 5 to 15% and get an INR in 1 week. If they have an INR between 4 and 5, omit 1 to 2 doses, decrease total warfarin dose by 10 to 20%, and get an INR in 1 week. If the INR is greater than 5, hold until INR is less than 3, decrease weekly dose by 20%, and get INR in 2 to 3 days. Restoration of sinus rhythm, electrocardioversion, and that is done with atrial fib that has been, patient can confirm that it's been less than 48 hours, and patient is hemodynamically unstable, meaning angina, hypertension. Those patients require immediate cardioversion. Atrial fibrillation greater than 48 hours or unknown, we want to heparinize, we want to get a TEE, and that TEE identifies any left atrial thrombus, which is a guide for cardioversion. EP studies, just like I said, they clarify the mechanisms of this. Where is this arrhythmia occurring? Can we identify areas that may need ablation and seek the sites, or any predisposing areas and tissue that predispose patients to atrial fibrillation that could be ablated and help this person to get the restoration of sinus rhythm. Bubble contrast with a transesophageal echo involves the injection of saline into a vein, followed by an echo study. The bubbles initially detected in the right atrium and right ventricles. If bubbles appear in the left heart, this may indicate a shunt, such as a patent form in ovale, atrial septal defect, ventricular septal defect, or AV malformations in the lungs. Ablation therapy is a cauterization of abnormal tissue responsible for arrhythmia. This is second line. In this procedure, the AV node is frozen or cauterized to stop electrical signals from being transmitted from the upper chambers, the atria, to the lower chambers, the ventricles, and a permanent pacemaker is implanted to control the heart's electrical system. This is AV nodal ablation. So this AV nodal ablation requires a permanent pacemaker, okay? So this is not what we go to right away. So we have cauterization of abnormal tissue responsible for arrhythmia, which we talked about. We can identify the tissue that's causing this. We're going to ablate it in the hopes that patient can be restored to normal sinus rhythm. We have AV nodal ablation. In this procedure, the AV node is frozen or cauterized to stop electrical signals from being transmitted from the upper chambers. But a permanent pacemaker is implanted to control the heart's electrical system. A lot of times you'll see patients get this procedure as they're going for open heart as well. The Mays procedure is a surgical treatment for atrial fibrillation. The surgeon can use small incisions, radio waves, freezing, or microwave or ultrasound energy to create scar tissue. The scar tissue, which does not conduct electrical activity, blocks the abnormal electrical signals causing the arrhythmia. The scar tissue directs electrical signals through a controlled path or maze to lower heart chambers, the ventricles. The Mays procedure is usually done during open heart surgery. The Mays procedure can stop atrial fibrillation in most people, but because of the risks involved with open heart surgery, this procedure is used only in people who have severe symptoms and do not respond to medicine or other treatment. This surgery may also be done with less invasive techniques, and the Mays procedure is frequently performed with other necessary cardiac surgeries such as coronary artery bypass or valve repair or replacement. So young patients oftentimes will get AV nodal ablation because it's preferred over years and years and years of drug anticoagulation treatment. Restoration of normal sinus rhythm can be medical, pharmacological cardioversion, and that really, it's not for AFib that's less than 48 hours. Recurrent AFib, despite multiple treatment attempts, poor tolerance of antiarrhythmic agents, advanced age, concomitant structural disease, left atrium greater than 6 centimeters, and presence of 6 sinus syndrome. And 6 sinus syndrome, the sinus node isn't working anymore. And you can go into a much lower heart rate after other cardiac cells will actually kick in and a slower pacemaker will take over. So we want to maintain normal sinus rhythm with medications. And these are commonly used drugs: covert, flecainide, Ticacin, beta-pace, Ridmol, amiodarone. These are medications commonly used for cardioversion. Multag, which is dronidodrone, dronidodrone. So it's DRONEDARONE. This is a non-iodinated derivative of amiodarone. Amiodarone affects iodine metabolism and it has a lot of side effects. This drug is non-iodine. It's a non-iodine derivative. And it has been shown to reduce atrial fib without the long-term serious effects of amiodarone. But there are concerns about safety in patients with severe heart failure. The choice of medication of these antiarrhythmics depends on patients' cardiac history. For example, flecainide and propafenone are preferred in patients with minimal or no heart disease and preserved left ventricular systolic function, whereas amiodarone and Ticacin are preferred in patients with heart failure. Patients with paroxysmal atrial fibrillation may use what is called the pill-in-the-pocket approach, where flecainide or propafenone, which involves taking a pill when an episode begins. So either flecainide or propafenone, which involves taking a pill when an episode occurs. This method is often effective in converting the rhythm to normal and alleviates the need to take antiarrhythmic medications long term. And the older agents, these are them: norpace, procainamide, quinidine, which were used. Procainamide is used in ACLS, but they're really used due to adverse effects for pharmacological cardioversion. Maintain best with patients in heart failure as amiodarone, and these are the dose. Dose is 100 to 400 milligrams daily. Dose adjustment for renal function and QT interval responses. loading dose of 600 milligrams a day times 1 month, and then 1,000 milligrams a day times 1 week. Adverse effects are photosensitivity, pulmonary toxicity, polyneuropathy, GI upset, bradycardia, Torsades de Pointes, a form of VTAC, hepatic toxicity, and thyroid dysfunction. Dofetilide is the dose is 500 to 1,000 micrograms daily. You need to adjust for renal function and QT interval. Adverse effects are Torsades, which is a form of ventricular tachycardia. And note that all arrhythmias, all antiarrhythmics are pro-arrhythmic, meaning they can cause arrhythmias. So they have to be monitored very carefully. So best in patients with minimal or no heart disease or preserved left ventricular systolic function and with paroxysmal atrial fibrillation of flecainide and propafenone. And those are the doses. So flecainide has VTAC, CHF, and conversion to atrial flutter, which is some of the side effects, and propafenone, adverse effects of VTAC, CHF, and conversion to atrial flutter. Beta pace is 250 to 320 milligrams a daily. Adjust for renal function and QT interval. Adverse effects are Torsades, CHF, bradycardia, and worsening of COPD. And these are older agents. Older agents. Procainamide is really coming back. The dose is 1,000 to 400 milligrams daily, but again, this can cause also a lupus-like syndrome and GI symptoms. Procainamide used to be really popular about 25 years ago, and then it came off because of the prolonged QT, but it's back. And quinidine 600 to 1,500 milligrams daily. You want to watch out for GI upset and then atrial fibrillation. Ventricular tachycardia. Atrial fibrillation and surgery. Tranexamic acid, which is an anti-fibrolytic drug, is what they give after or before surgery with a mouthwash, and this prevents excessive gum bleeding without interrupting any anticoagulation therapy. So tranexamic acid, which is an anti-fibrolytic drug that they give prior to dental surgery. Major surgery, they'll most likely have you stop 4 to 5 days before the surgery. Remember, warfarin has a longer half-life. Post-op, we want to resume anticoagulation with the combined low molecular weight heparin and Coumadin until the therapeutic INR is achieved between 2 and 3, and then DC the heparin. Minor surgery if patients who have atrial fibrillation, step 1 is you want to obtain an INR 5 days before procedure. Step 2, you want to stop the warfarin 1 to 5 days before surgery, depending on the INR. An INR of 2 to 3, stop 2 days prior to surgery. An INR of 3 to 4, stop 3 to 4 days prior to surgery. An INR greater than 4, stop 5 days prior to surgery. The evening following the procedure, you want to restart Coumadin, and if no bleeding, replace missing doses of warfarin on a day-to-day basis. Step 4 is check INR 5 to 7 days after procedure. Monitoring older than 65 years of age, history of stroke, history of GI bleed, history of renal insufficiency, history of anemia, those with orthostatic hypertension, epistaxis, bleeding gums, melena, hematochezia, hematuria, and hematoma. Melanin is the passage of dark tarry stools containing decomposing blood that is usually an indication of bleeding in the upper part of GI tract, and especially the esophagus, stomach, and the duodenum. That means that blood has been digested, and that occurs in the upper GI. Hematochezia is the passage of blood in the feces. Herbal interactions, carnitine, papaya juice, some of the stuff I've never heard of, grapeseed, leaf extract. Here is a list. Polycosanol is a mixture of primary alcohols derived chiefly from this waxy coating of sugarcane, and is used especially in dietary supplements to lower cholesterol levels. So these can actually increase the INR and decrease INR. As astriol, a West Indian shrub with mild acid cherry-like fruits rich in vitamin C, and they decrease the INR. Avocado, psyllium, cabbage, ginseng, green tea, and rosehip also decrease INR. So you definitely have to ask if these patients, again, if you're having a hard time, make sure that you've asked and questioned them about herbal interactions. Tons of drug interactions with Coumadin. An increase in INR with the following medications: Tylenol, allopurinol, amiodarone, aspirin. Antibiotics are a big one. Big one. Ibuprofen, Indocin, influenza, lovastatin, antifungals, flagyl influenza vaccine, Bactrim, tricyclic antidepressants, vitamin A and vitamin E in large doses, and then decreasing INR. These are the medications. Grisfluvin, which is an antibiotic used systemically in treating superficial fungal infections. Barbituric, carbamazepine, estrogen-containing contraceptives. Cortisone, Haldol, spironolactone, trazodone, vitamin C in large doses, and vitamin K containing supplements. So we talk about aortic stenosis, stiffening the aortic valve, increased resistance to left ventricular outflow, most common surgical valve lesion in developed countries. What occurs here is a progressive calcification of the aortic valve. Less commonly follows rheumatic heart disease. 25% of patients are over the age of 65 years of age. 35% are greater than 70 years of age. 10 to 20% develop hemodynamically significant stenosis, and this is 3 to 5 times more frequent in males. Risk factors are tobacco use, male gender, and hypertension. Signs and symptoms: frequently asymptomatic symptoms. Murmur, systolic murmurs at the second intercostal space, right sternal border. Palpable thrill at the right sternal border. Auscultation of murmur comes before the clinical symptoms. Murmur transmits to carotid artery. Make sure you check the neck with your stethoscope. Chest pain could be due to aortic stenosis. 50% of these patients have associated coronary artery disease, also have that exertional syncope. Okay? EKG may suggest left ventricular hypertrophy. Chest X-ray shows enlarged cardiac shadow, calcification of the aortic valve, dilation and calcification of the ascending aorta, and echo you want to look at to assess valve thickness and function, and cardiac cath is used for definitive diagnosis. On EKG, you most likely will have left ventricular hypertrophy due to the stenosis and the blood pumping out from the left ventricle into the aorta. It's stenosed, so that left ventricle is pushing against a valve that's narrowed, and that left ventricle becomes bigger. So some of the EKG findings, an R wave in AVL is greater than 11 millimeters, or an S in V5 or V6 greater than 27 millimeters. And again, S in V1 plus an R in V5 or V6 that is greater than 35 millimeters, or an R in AVL greater than 11 millimeters. And these are all examples, or an S in V5 or V6 greater than 27 millimeters are all examples of left ventricular hypertrophy. And this is example EKG showing left ventricular hypertrophy. AVL, an R in AVL that is greater than 11 millimeters, and that is definitely almost at 11 millimeters. An S in V5, which is greater than 27 millimeters. That's the S, okay? Or V6. Again, large QRS wave right here. QRS wave. S wave down. Okay? Treatment. Surgical interventions for symptomatic patients. We have the Roth procedure, which is a type of specialized aortic valve surgery where the patient's diseased aortic valve is replaced with his or her own pulmonary valve. The pulmonary valve is then replaced with a cryopreserved Godiva pulmonary valve. In children and young adults or older, particularly active patients, this procedure offers several advantages over traditional aortic valve replacement with manufactured prosthesis. The longevity of the pulmonary autograft in the aortic position is superior to any bioprosthetic, such as a porcine valve, which tends to degenerate after only a few years in patients under the age of 35 years of age. Furthermore, anticoagulation is not required as with mechanical valves. Thus, individuals can lead an active life without the risks associated with anticoagulation therapy. This is especially important for women of childbearing age needing aortic valve replacement, as anticoagulation is contraindicated in pregnancy. Balloon valvuloplasty is also another option. Surgical intervention for patients who are symptomatic. Mitral valve prolapse. You have decreased ventricular load resulting in prolapse of the valve leaflets during systole. Displacement of an abnormally thickened mitral valve leaflet into the left atrium during systole. A non-classic form, low risk of complications, is a displacement of less than 5 millimeters. And classic form, high risk of complications, displacement of greater than 5 millimeters. Complications include mitral regurgitation, infective endocarditis, and cardiac arrest. The etiology and demographics of mitral valve prolapse. Connective tissue disorders. These are patients with rheumatic endocarditis. Rupture of chordae tendineae. This is more common in females and more common in thin patients and those with a family history. Mitral valve prolapse should probably be thought of as a continuum from the exaggeration of the normal to the slightly billowing of the mitral valve into the left atrium, and that occurs during systole, to a fully floppy valve, and finally to a variable degree of mitral regurgitation when the floppy redundant leaflets no longer are able to fit together well. At times, the regurg may become severe, often as a result of the rupture of the chordae tendineae. So we have multiple valve prolapse, which causes the rupture of chordae tendineae, which causes mitral regurg. Signs and symptoms may be asymptomatic. Patients may have nonspecific chest pain, anxiety, palpitations, fatigue, dysrhythmia, mid-systolic click, or late systolic murmur. Other causes of systolic murmur are aortic stenosis, infective endocarditis, subvalvular dysfunction, and tricuspid valve disease. Those are other causes of systolic murmur, and also are you differential, meaning this necessarily doesn't might not be mitral prolapse or mitral regurg. They could be other things going on: aortic stenosis, infective endocarditis, and subvalvular dysfunction or tricuspid valve disease. Diagnosis is usually clinical. Patients may also have a mid-systolic click, followed by a late systolic murmur, heard best at the apex. You need an echo to confirm. You're looking at left atrial enlargement, ventricular hypertrophy in advanced stages. Most required for mitral prolapse, no treatment. Antibiotic prophylaxis for invasive procedures when clinically significant murmur is present. Beta blocker if supraventricular dysrhythmia is present, and surgical intervention if severe. Endocarditis is a systemic infection beginning with an infective organism on the valve, progressing to bacteremia. We're seeing tons of this because of the opioid addiction with intravenous drug abuse. Young people, and I know most of you have probably taken care of these patients. Inflammation of the inside lining of the heart chambers and heart valves, and these are the most common organisms. You need to know that for the exam. These are very, very important. Veridans, that is the most common. You need to know that, highlight that. Risk factors: pre-existing murmur, congenital lesions, again, rheumatic heart disease, transient bacteremia, history of like sepsis, if you will, injection or drug use, and prosthetic heart valve are risk factors. Signs and symptoms are fever, arthralgia, dyspnea, changing murmur, splinter hemorrhages, Osler nodes, Janeway lesions, Roth spots, or subconjunctival hemorrhages in the eyes. These are Janeway lesions. They are small, painless, red, as you see, blue macular lesions, a few millimeters in diameter, that are found on the palms and soles in patients with subacute bacterial endocarditis. Janeway lesions are non-tender, small, erythematous, or hemorrhagic macular nodule lesions on the palms or soles. They are caused by septic emboli, which deposit bacteria, forming microabscesses. Osler's nodes, differentiated from Janeway lesions because these are painful and tender, whereas Janeway lesions are non-tender. Okay, so you need to know that. These are small, tender, cutaneous nodes, usually present in the fingers and toes, that may be seen in subacute bacterial endocarditis. The nodes are caused by emboli dislodged from infected heart valves. Subconjunctival hemorrhage in the eye. Roth spots are retinal hemorrhages with white or pale centers composed of coagulated fibrin. Roth spots may also be observed in patients with leukemia, diabetes, subacute bacterial endocarditis, those with pernicious anemia or ischemic events. So if we see these not normal, we might be able to know what it potentially is. When we look in the patient's eyes in the methadone clinic, we're looking for this. We most likely will see someone with this. Haven't yet, but we'll let you know. Diagnostic studies, blood cultures, echo, transesophageal echo, greater than 90% sensitivity for valvular lesions, leukocytosis, which is an elevated WBC. Major criteria is positive blood cultures for infective endocarditis. And the major one, which you have to know, are typical microorganisms consistent with IE, which is endocarditis, infective endocarditis, from 2 separate blood cultures as noted below. Viridin streptococci, or community-acquired Staphylococcus or Enterococci in the absence of primary focus, or microorganisms consistent with infective endocarditis from persistently positive blood cultures, defined as 2 positive blood cultures of blood samples drawn greater than 12 hours apart, or all of 3 or majority of 4 separate cultures of blood, with first and last sample drawn 1 hour apart. So 2 positive blood cultures of blood samples drawn greater than 12 hours apart. And then typical microorganisms consistent with infective endocarditis from 2 separate blood cultures as noted below. And these are major criteria. Positive echocardiogram for infective endocarditis defined as oscillating intracardiac mass on valve or supporting structures in the path of regurgitant jets or implanted material in the absence of alternative anatomic explanation. This can be due to an abscess or a new partially dehiscent prosthetic valve or new valvular regurgitation, worsening or changing of pre-existing murmur not sufficient. So these are evidence of endocardial involvement, which is an abscess, which can be an abscess, new partial dehiscence of prosthetic valve, which is not good, or new valvular regurgitation. So a new valvular regurgitation, which oftentimes you will hear with a changing of a pre-existing murmur. So here we have a table which shows us the major criteria. You need to know this. So it's positive blood cultures and evidence of endocardial involvement on an echo. Minor criteria are fever greater than 100.4, predisposing cardiac conditions, vascular phenomena, immune phenomena, microbiologic evidence, and echocardiac findings. Vascular phenomena are atrial emboli, septic pulmonary emboli, mycotic aneurysms, intracranial hemorrhage, conjunctival hemorrhage, Janeway lesions. Immune phenomena are positive rheumatoid factor, is also nephritis, inflammation of the kidneys, Osler's nodes, Roth spots. Microbiologic evidence is positive blood cultures that do not meet criteria, or serologic evidence of active infection. And echocardiographic findings are consistent with infective endocarditis, but do not meet a major criteria as noted above. So, treatment, hospitalization initially for antibiotic therapy, usually 4 to 6 weeks. Empirical regimens while CNS is depending. Agents active against staph and strep and enterococci. These are the antibiotics that we use: nafcillin, oxacillin plus penicillin plus gent, and vanco instead of penicillin if MRSA is suspected. Viridin, strep, penicillin G, enterococci, penicillin G, and strep, or gentamicin. methicillin, Staph aureus, methicillin-sensitive Staphylococcus aureus, a kind of bacteria, nafacillin or oxacillin, and MRSA, vanco, amphotericin B for fungal endocarditis. Prophylaxis to prevent bacterial endocarditis, prosthetic cardiac valve, patients with previous infective endocarditis, cardiac transplant recipients who develop cardiac valvulopathy, unrepaired cyanotic congenital heart disease, and these are completely repaired congenital heart defect with prosthetic material or device during the first 6 months after the procedure. Repaired congenital heart defect with residual defects at the site or adjacent to the site of prosthetic patch or a prosthetic device. I have posted online the new guidelines for the prophylaxis for dental procedures, and they're indicated for high-risk patients that require endocarditis prophylaxis for all dental procedures that involve manipulations, gingival tissue, or pre-apical, which is the root area of teeth, or perforation of the oral mucosa. Not indicated for routine anesthetic injections through non-infected tissue, taking of dental x-rays, placement of removable orthodontic appliances, adjustment of orthodontic appliances, placement of orthodontic brackets, shedding of deciduous teeth, which are baby teeth, and bleeding from trauma to the lips or oral mucosa. Not indicated for people undergoing dental procedures who are not at high risk for bacterial endocarditis. People undergoing non-dental procedures at the following sites: upper and lower GI tract. GI tract includes urologic, gyno, and OB procedures in childbirth. Also, individuals with upper and lower respiratory tract include ear, nose, throat procedures, and bronch. And these are not indicated for prophylaxis. Dental prophylaxis, these are some of your options: amox, adult 2 grams, child 50 milligrams per kg, orally 1 hour before procedure, if they meet the criteria. Unable to take oral agents, ampicillin, adult 2 gram, child 50 milligrams per kilogram, IM or IV 30 minutes before procedure. It's not 50, I said 50 mgs, no, it's 50 milligrams, okay? Cefazolin or ceftriaxone, adult 1 gram, child 50 milligrams per kilogram IM or IV 1 hour before procedure. Allergic to penicillin or AMP, we're going to give Clinda 600 milligrams PO 1 hour before procedure. Keflex, cephalexin, adult 2 grams PO 1 hour before procedure. Zithromax or Biaxin, adult 500 milligrams PO 1 hour before procedure. If you're allergic to penicillin and unable to take oral medications, Clinda, you can give adult 600 milligrams IV within 30 minutes before procedure. And cefazolin, 1 gram IV within 30 minutes before procedure. Lastly, we're going to talk about pericarditis, which is acute painful inflammation of the pericardium, which involves a sac covering the heart. The pericardium becomes inflamed. You have acute versus chronic versus mild or self-limiting. The etiology or risk factors, it can be a virus, bacteria, post-MI, renal failure, tuberculosis, neoplastic cancer. Those with collagen disease, it can be drug-induced. It can be caused by a trauma. And collagen disease, an example of that will be scleroderma. So patients often complain of signs and symptoms with pericarditis. They're in a lot of pain, more so than someone who's having acute MI. Oftentimes they can't get comfortable. They have to be at the bedside in a hunched position. They're in a lot of pain. Retrosternal or pericardial chest pain, pain increased by deep inspiration. So that's oftentimes what you want to ask patients if they have pain during inspiration. coughing, swallowing, recumbent position. Pain relief by sitting forward. That's very classic. So lying down, they're not comfortable. They'll be over the bedside table leaning because that makes them feel more comfortable. Shortness of breath secondary with pain with inspiration. Pericardial friction rub, pleural friction rub, and fever depending on underlying cause of pericarditis. So differential diagnosis, again, is this person having an MI, or are they having costal pain? Costal condyle pain relating to joining a rib and costal cartilage. Is this pleurisy? Is this dyspepsia, painful digestion, or a pneumothorax? Diagnostic studies, leukocytosis with elevated WBC, ST segment elevation in all leads, return of ST segment to normal within a few days, followed by temporary T wave inversion. You have a depression of PR segment, highly indicative of pericarditis. You have a SED rate. Get a SED rate. These are always elevated. Blood cultures, if bacterial cause is suspected, and echo confirms presence of pericardial fluid. Again, this is a great, all leads are showing, like they're all abnormal, this EKG, every single lead. This is acute pericarditis. Treatment for this is nonsteroidals, indocin, analgesics for pain, antifungal medication if it's fungal pericarditis, steroids with treatment failure of nonsteroidals, diuretics to remove excess fluid from pericardial stack, and antibiotic if bacterial infection. And that's it for today. That's a lot of information. We're going to be going over case studies, particularly with patients with infective endocarditis. We'll be doing atrial fib, and we will be talking in class about the new oral anticoagulants.